like to talk about something that I'm extremely passionate about. It really fascinates me, and I decided to dedicate my life completely to that, and that's anti-aging and regenerative medicine, age reversal, and disease reversal. Before I proceed, I'd like to introduce myself. My name is Dr. Dmytro Klokol. I'm a medical doctor specialized in surgery, and I did a PhD in reconstructive surgery. I was associate professor in the Department of Surgery when I was still working and living in Eastern Europe and Ukraine. And then I was blessed and I was lucky enough to work in different countries, many countries, and not only in different countries but also in different continents. So more than 10 years ago, good luck, fortune sent me to work in Asia. So I was working in Malaysia for years, and then I even had a great chance of winning the grant from Japanese Society of Veterinary Surgeons for the clinical study and research that we've done in Malaysia. And regenerative medicine and stem cell treatment were always my passion. So about 5 years ago, after I'd done some initial postdoctoral study in regenerative medicine and tissue engineering, I decided to dedicate myself completely to regenerative medicine and stem cell treatment. So it's a financial disclosure. I have no conflicts. I'm not getting paid extra for this presentation. I have no commercial benefits, much of it. And the main learning objectives are here on the slide. My main objective today is to continue the discussion regarding the place of the stem cells in regenerative medicine, and mostly about finding the right place for it, and also choosing the most appropriate type of cell therapy products, because cell therapy has a huge variety, a huge range of different products, starting from stem cells and various pericrine factors, growth factors, and so on and so on. And it's my task today and throughout my life to find the best solution, the best type of cell therapy, and not only the best type of cell therapy, but find the most appropriate ways of implementing cell therapy. What should be the right time to do it? I like to build today's talk on a very simple model. It's a problem, solution, action. So we're going to talk, identify problems, and we're going to find different solutions, and probably find what is the best solution, and figure out how we can place that properly in our treatment paradigm so that we get the best benefit for our patients. And the problem number one was identified a very long time ago. We're talking like 2,000 years ago in ancient Greece and ancient Rome, when people understood that in order to fight the disease, we have to fight aging first. And that's what Cicero said. Of course, he didn't say it in English, he said it in Latin, but if you translate it, it sounds like we have to fight against aging as we do against a disease. Fast forward 2,000 years, the problem is still the same. However, we have learned something new. We have learned that we can manipulate and we can influence these processes, and we have learned that we can actually somehow postpone the aging or even reverse it, and together with that we can treat chronic age-related degenerative diseases, because the age itself has been recognized as the main factor for a large number of chronic age-related degenerative diseases. The problem number two is that we are a tremendously aging civilization. It's a data from the United Nations organization saying that between 2015 and 2050, the population of people who are older than 85 years old is tripling. At least if you take United States of America, people who are 65 years old and above, 2/3 of them have at least 2 or more chronic age-related degenerative disorders, and 90% have at least one chronic age-related disease. And the list of those diseases includes all of these conditions, but not limited to this list. Indeed, medicine made us live longer, but unfortunately not better. And I believe that's the anti-aging and longevity medicine and regenerative medicine. That's our task number one, to make people live better, as well as live longer. So where does the healthy aging ends and the age-related diseases start? It looks like that, it appears that mechanisms and drivers of aging and age-related disease are almost the same, and the line between them is very thin and sometimes not even visible. It's a very nice study, a very nice article quoted here. And one of the conclusions of this fantastic review that the authors came to is that medicine should combat all age-related diseases at once and not one by one. So how do we actually do it? And to understand that and to do it properly, we should not employ and follow the same reductionist approach that conventional medicine is doing by approaching only the visible part of the iceberg and treating the symptoms and some conditions which are fully clinically manifested. It's just melting the iceberg, you know. But let us, instead of melting the iceberg, let's flip it and address the conditions which are submerged underneath. And those are the conditions which are the actual drivers of aging. And a few years ago, in 2016, in the journal Cell, they were identified as 7 pillars of aging. Those who are familiar with Aubrey de Grey's work, he's calling them sometimes the 7 deadly things, but principally it is almost the same. So these drivers of aging are unique, universal mechanisms of aging. They also promote the development of all age-related disorders. And we're talking about the disruption of metabolism, the macromolecular damage, the epigenetic changes, which we're going to talk about later, chronic systemic low-grade inflammation, impaired adaptation to stress, impaired proteostasis, and loss of ability of the cells and tissues to utilize those the metabolites and toxic products of its metabolism, and reduction of the stem cells and loss of the regenerative potential of the stem cells. So, stem cells, whether it's intrinsic as intrinsic factor for the tissue repair, but as well as these factors, they influence in a very negative way the outcomes of the stem cell treatment and cell therapy. So the moral of the story is, unless you correct all these things, your cell therapy and your stem cell treatment may not work as great as you expected it to work. Lucky for us that parallel to identifying the common drivers of aging and age-related diseases, we also have learned that cellular aging can be delayed and reversed with genetic, dietary, pharmacological, biological, and biotechnological approach. Research for the past years has sort of gave us an idea that there are certain mechanisms and there are certain biological and pharmacological and biotechnological approaches that can actually, essentially and effectively, reverse and postpone aging. So it starts with 2 very simple biological mechanisms that sort of trigger, they switch on the genes of longevity. It's a caloric restriction and high intensity training. It's a very simple but extremely effective proven biological mechanism to activate the genes which are responsible for the cellular youth and longevity. And also in the same time, the application of such treatment modalities as resveratrol, metformin, and the NAD. In the same time, the NAD is the catalyst of these biological reactions that improve the ATP production, mitochondrial function, and they will stimulate the expression of the longevity genes on the cellular level, plus the application of senolytic drugs. And how is it all related to the stem cells? Well, very, very simple, because lack of appropriate regulatory signals, it results in failure of stem cells to survive. And in the end, they do not perform grafting, they do not home, but they just perform the pericrine effect, which also is not so bad. So the NPK sirtuin system dysregulation itself is a part of normal biological aging. And it is actually can be worsened by overnutrition or improper lifestyle, various genetic and epigenetic factors. And it results in such pathological changes as altered of the lipid metabolism, hyperinsulinemia, increased other stress hormones as well. Insulin promotes insulin resistance. It causes and triggers and supports that chronic low-grade inflammation, promotes oxidative stress and mitochondrial dysfunction. And all that results in such age-related disorders as metabolic syndrome, diabetes type 2, hyperlipidemia, cancer, increased rate of various forms of dementia, including Alzheimer's and so on. And hyperactivation of the mTOR gene also, it is highly associated with the disruption of the NPK system as well. So the dysregulation of AMPK and sirtuins, apart from triggering all these pathological changes, it also reduces regenerative potential of stem cells, both endogenous and the stem cells which we can use as a treatment tool. So the upregulation or activation of both the sirtuin system and the AMPK, whether by calorie restriction or exercise or pharmaceutical intervention or stem cells, it all leads to reduction in better outcomes of stem cell therapy and, of course, age reduction, and overall it changes the biology of the cell. So do we know how we age and how we develop age-related diseases? Yes, we do. And can we reverse aging on the cellular level? Yes, we do. At least we know how to do it. So the question is, why do we still develop chronic degenerative diseases, and why still the outcomes of treatment of these disorders are not really satisfactory? And the answer for that was given about 140 years ago in Freiburg University by Professor August Weismann, who said that death takes place because a worn-out tissue cannot forever renew itself, and because the capacity for increase by means of cell division is not everlasting but finite. So technically, 140 years ago, he explained how we develop age-related degenerative diseases, and essentially it's either abnormal function or loss of the cells in the tissues, as well as degradation of the extracellular matrix. And throughout this past century, we have learned that these changes are both reversible, and it is called tissue remodeling. So let's just find the ways how to achieve it. And to achieve that, we have to tackle the 7 pillars of aging, which probably we can achieve with all these novel strategies, with the AMPK activators and so on. And task number 2, or the problem number 2 that we have to solve, is how to achieve effective tissue regeneration and remodeling. And the answer for that, the understanding of how to succeed in tissue remodeling, probably lies in embryology. So the natural development of tissues carries the answer how we can regenerate tissue using the natural biological pathways. And that's what biological regenerative medicine is all about. It's a use of naturally occurring substances from the living organism, whether it's a plant, animals, other human beings, and so on, for the purpose of cell replacement, tissue regeneration, and organ regeneration. So we have to look at the nature as the great visible engine of creativity. And the best tool and the easiest tool to use probably, and it's something that can be used in practically every anti-aging practice all over the world, is a stem cell technology. We don't have the organ bioreactors first and organ generators and all. It's something still of the future, you know, it's sort of like a sci-fi. But what we have here and in all countries in the world are the stem cells. The cell therapy, various forms of cell therapy. So we just have to learn what exactly, which products to use, when to use, and how to use them correctly. We have published recently an article which explains the historical aspects of cell therapy, how it was developing, and also the mechanism of action, its safety, and success stories. So let's go through that briefly. As everything in medicine, before we talk about mechanism of action and the outcomes and effects, we have to talk about its safety. And although there's been plenty of publications on the safety of the stem cell therapy, because in this particular study we're working with the xenogeneic product, so we had we felt the need of running the safety study, and so that it's not biased, we have employed a third party. After 1 year, more than 1 year, there were no unwanted, some negative side effects or adverse reactions or whatsoever. The clinical improvement rate was very high, and the treatment was very much synergetic with the treatment that patients were undergoing in the primary treatment facilities, because mostly these are international patients. And the desire to repeat this therapy is also very high. It's 97%. So a huge number of patients, they really appreciate this treatment, and they keep on coming back, and they really enjoy the benefits of it. How does it end? Now this is a desired, so-called hypothetical mechanism of action, which in reality does not work 100% of cases. And we're going to explain why and what to do about it. So ideally, the pathway number one, the mechanism of action of cell therapy, is it's homing. Either it's a local homing in the site of the implantation, or it's a distal homing after the cells or cell therapy products will migrate and finally home to the either area of the inflammation or ischemia or tissue damage, or according to the organ specificity. Ideally, after the homing is performed, there's supposed to be further proliferation and final differentiation of the cells, which, as I said, unfortunately doesn't happen in 100% of cases. The second line is the paracrine effect. The paracrine effect is done by the release of large number of growth factors that further promote the survival and the differentiation and the growth of the stem cells, both endogenous and the stem cells which are exogenous, which are implanted or transplanted or transfused to the patient as a treatment modality. It was also noticed that the amount, the expression of those growth differentiation factors, it influences the outcomes and the fate of stem cells tremendously. For example, one of the best examples is the GDF11, the growth differentiation factor 11. There was an experimental study done when they've compared young and senile individually. It was done on mice, and they transplanted the neural progenitor cells, and further they monitored the survival rate and engulfment of those cells, and it was noticed that cells behave much better in younger individuals. However, if you were to combine stem cell transplantation with the simultaneous administration of specific growth differentiation factors, like the GDF11, for example, you tremendously increase the outcomes of cell therapy. You improve the survival of the stem cells, you improve the engraftment rate, and it can be in all senile individuals as good as in young individuals. Apart from these paracrine factors, they also promote angiogenesis, or neoangiogenesis. That's very important, because if you will regenerate tissue without re-establishing the blood supply, or without revascularization of a newly regenerated tissue, high chances that these tissues, newly regenerated tissues, will not survive forever, okay, or for a long time. So you'll have a very short-term effect. So it's very important that there is a multi-step treatment. So before, during, and after, and sometimes it goes for as long as 3 to 4 months after the stem cell implantation, we administer various growth factors that, in its turn, they will promote the further tissue remodeling, and of course they improve the survival of the stem cells that were transplanted to patients. Apart from neoangiogenesis, the paracrine factors, or the growth factors, they will also reduce the apoptosis, and overall they will reduce the fibrosis in the tissues. Last but not the least mechanism of action of stem cells is its immunomodulatory effect. So you know that immune system, you can consider it as any other system in the body. It also is a subject to aging. It's called immunosenescence. And immunosenescence on the background with a chronic systemic low-grade inflammation. It is known nowadays that people call it inflammation. So it's made mostly two phenomena. It's expressed or elevated cytokines and reduced inflammatory responses. When people accumulate large amount of the age-old memory cells, immune cells, but they lose the ability to produce new functional lymphocytes, so mostly it's because of the type of function decline and so on and so on. So stem cells, they do activate immune cells, and also they perform a very strong anti-inflammatory effect. And you can say that the effect of the stem cells generally is also synergetic with other treatment modalities, and it's targeting those 7 pillars of aging, those 7 main drivers or mechanisms of aging, and promotes its reversal. We are very interested how stem cells interact or how they influence the mitochondrial function and the antioxidant protection system. For that purpose, we have done a study also. We have tested some of the mitochondrial peptides, like the small humanin-like peptides, 6 fractions, and serum humanin in our patients, as well as the SOD, the superoxide dismutase, catalase, and reduced glutathione. What we have seen is that the mean levels of the mitochondrial function in most of the patients. And the inclusion criteria for this were patients with at least one or more of chronic age-related degenerative disorders, and none of them were in acute state, just the chronically ill patients, usual patients probably you're dealing with on a daily basis. So the humanin, which is one of the mitochondrial peptides, it has a very strong role. The prominent role is in neuroprotection, so mostly it's a factor that is protecting us from neurodegenerative disorders, dementia, Alzheimer's, and so on. So on a mean level, on average, it was tremendously reduced. It did pick up almost to the normal level 8 weeks throughout the cell therapy. Same the small humanin-like peptides, and the fractions 2, 3, and 4, their low levels are strongly associated with metabolic syndrome, obesity, diabetes type 2, and these are the main age-related diseases. They were also normalized 8 weeks through the cell therapy. The reduced glutathione did improve a bit, not really statistically significant, and it was in suboptimal level, but antioxidant protection by the superoxide dismutase and catalase was normal 8 weeks throughout the treatment. What is the most frequent and easiest to procure type of the stem cells that practitioners use all over the world? It's the MSCs. Why it is so? Because it is the easiest type of the stem cells to procure and produce. MSC is considered to be a pluripotent multipotent cells. They can differentiate into 7 types of tissues. Yeah, so they can produce bones, they can regenerate tendons, ligaments, muscle tissue, skeletal muscles, not the cardiac muscle, not the myocardium. They can also, there are hematopoietic cells, and they can differentiate into adipocytes. And unfortunately, in the aging individuals, that's what is happening most of the time. So, by any stretch of the imagination, these cells cannot perform an effective tissue repair for the rest of the tissues, whether you're talking about the parenchymal organs, whether you're talking about the brain, and so on. So, their differentiation potential limited only to these 7 types of the tissues. It's like, I have good and bad news for you, okay, so let's talk about good news first. The good news is that MSCs generally, they have a tremendous beneficial effect, yeah? They reduce inflammation, they have a very strong anti-inflammatory effect. They stimulate both endogenous and the exogenous progenital, the precursor cells, transplanted or available in the tissues if they're available. And also they improve the survival of the transplanted tissue-specific cells, which we're going to talk in a minute. They have a low engraftment rate. It's just because 99%, maybe even 100% of these cells are just trapped in the lung tissue. It's probably bad news for those who do not have the COPD or pulmonary fibrosis, but it's great news for patients with COPD and pulmonary fibrosis, or the patients with the primary pulmonary hypertension, those who mostly benefit from the intravenous infusion of these cells. However, other patients, other disorders, they might not benefit as much as patients with a lung problem. If you will culture these cells, because they still carry the pluripotency, the more you culture them, the more dangerous they are. And also, when you look for the provider, always check how many passages of the MSCs. Ideally, not more than 3. Those 5, 6 passages and above, high chances that they will accumulate genetic mutations and might not be as effective as you expect them to be. There are also autologous stem cells, which, for example, the adipose derived. And the older patient is, and the more obese patient, the less you will have therapeutic effect, and the more side effects and complications for that. Sometimes it goes to the level that it even makes the situation worse, because the MSCs, they have sort of 2 fractions, MSC 1 and 2. One is anti-inflammatory and second one is pro-inflammatory. So if you harvest it from a patient with obesity, metabolic syndrome, who is not properly prepared for this, you will only make their metabolic syndrome worse, not even talking about flaring up autoimmune diseases and so on. Limited differentiation potential, well, because we have 200 over close to 270 different types of tissues and cells, and these cells can only differentiate into 7 types of cells. And all of this ends up with just having a very short-term effects. How short are these short-term effects? Let us be honest, counted by days or weeks. Okay? The actual therapeutic effect from MSCs does not even survive or go through 4 weeks. So how can we repair tissues? That effective tissue repair and regeneration is possible only via the lineage-restricted precursor, also known as progenitor cells. Some people call them stem cells, some people not, but still they carry the stemness potential. And these cells, they have the ability to differentiate into specific type of cells and replace damaged tissue. Okay, so we have close to 270 different types of tissues, and every terminally differentiated cell has its progenitor, its precursor, the cell which is just one step before the final differentiation. And with that, those type of cells only, that's beyond the shadow of the doubt, you can actually perform the effective tissue repair. Those of you who are familiar with this person is Professor Multimodal. He's one of the people who have discovered the first precursor cells isolated from the central nervous system. They've isolated, purified, they expanded the volume of the cells, they cultured precursor neural cells, and they've transplanted those cells to patients with spinal cord injuries and demyelinated diseases, and they had tremendous outcomes, wonderful outcomes in terms of successful repair of the spinal cord. So another benefit, of the work of this person is that he actually discovered the pathways that provide the first molecular mechanism linking changes in the redox state, literally in the metabolic regulation of precursor stem cell division, differentiation, and survival. Okay, so if you use precursor stem cells without a clue, it doesn't mean that they're going to survive. There is absolute imperative to create a specific environment in the tissues, a specific environment in the patient body that enables the patient to accept those cells properly and the patient cells to survive and further proliferate and differentiate. So we're moving from the pluripotency, pluripotent multipotent cells, which the MSCs are, towards tissue-specific progenitor or the precursor cells. We're not using terminally differentiated cells yet, and probably will never use that because of various reasons. Yeah, but when you do the cell-based transplantation, it's mostly done with the precursor of the progenitor cells. So what we have, what we advocate, and not only us, it's from point of scientific research and common sense, I believe that's how it should be, is that there has to be a multi-step, multimodal treatment approach to cell therapy. It starts with the non-specific MSCs. We call them non-specific in our practice, and they perform immunomodulatory function. And also, that's another very important component, they prevent the graft versus host disease. So whatever tissue-specific cells you're going to do transplantation after that, next day, within the next few days after the MSCs, very high chances that there will be no very minimal immune reaction or rejection of these cells. And usually there's no immunosuppression or something needed to be given along with this type of therapy. They also promote the reduction of fibrosis, stimulate the formation of new blood vessels, and they perform mitochondrial transfer. Okay, so literally the MSCs, they're able, transplanted MSCs, to transfer the mitochondria into the recipient cells. However, and it's clear, absolutely clear, and I don't think that anyone should doubt it, and any person who still would continue to pursue the idea, insists that MSCs do engraft in damaged tissues, at least risks to be called insincere. It is quite clear that MSCs do not differentiate in vivo. Okay, they do not perform engraftment. The engraftment rate is close to 0%, and they act only via the paracrine mechanisms, which is great enough. Yeah, it's great. They create a beneficial environment in the patient. However, they do not engraft, but they will promote a successful engraftment of the tissue-specific cells, the progenitor cells, and they will promote their survival, they will support their proliferation. And in combination, the non-specific MSCs with the tissue-specific cells, they can promote and produce a very solid results in the form of tissue remodeling and repair. It's like a shotgun and a sniper rifle. The MSCs, just a shotgun, shoots everywhere. And the rifle, sniper rifle, that's an organ-specific or tissue-specific precursor stem cells. That's how they look like in a blue stain. It's cultured neurons. That's cultured pancreatic islet cells in blue and with a mitochondria stain. That's the xenogenetic mesenchymal cells. That's neural cells with a neuron-specific enolase used as a biomarker to identify those cells. So let's talk about clinical applications. Who knows about Carl Gustav Groth? Who have heard about this person before? Late, unfortunately. But he was a wonderful scientist and surgeon from Karolinska University in Sweden. And in 1994, he was one of the first people who did the xenogenetic stem cell islet precursor cells, pancreatic cells transplantation to his patients with diabetes type 1. And he had quite good results. About 60% of the patients, they had improvement in glycemic control. There were some anecdotal cases of complete cure or reversal of diabetes type 1. And it's very well published. If you just look at it, it's published mostly in Europe. And he was not the only one. There were other groups and researchers who continued that, and it was going on until 2010, so probably even continuing now. So it's a transplantation or xenotransplantation of different origin. It doesn't matter, the origin doesn't matter as long as you have a complete control over the source of the cells. Of the neonatal and the fetal precursor islet cells, 2 patients with diabetes type 1. And both experimental and clinical data shows that at least 150 to 300 days following the transplantation of the cells, there is foreign insulin produced endogenously in the patients. It tremendously improves the glycemic control. It prevents the development of complications of diabetes. And of course that's done for the diabetes type 1. When we treat patients with diabetes type 2, our main target is the repair and reversal of the damage which is done to the target. So we mostly focus on treating the CKD or diabetic nephropathy or diabetic retinopathy, the chronic liver disease and metabolic syndrome with targeted specific cell therapy. Chronic liver disease, and it doesn't matter what we're talking about, whether it's a chronic or acute liver injury, and what is the etiology of the disease, it doesn't really matter whether alcohol-induced or non-alcoholic steatohepatosis or toxic hepatitis, fatty liver disease. The approach to the patient selection is the same as approach in hepatology and liver surgery when we put patient on the transplant list. So we use the model of the end-stage liver disease. And as long as the patient is not terminally ill, when the predicted lifespan is at least 3-4 months or more, this patient can go effectively for the hepatocyte transplantation. The benefit of it is that it's almost unlimited amount of the cells that can be transplanted. You can do it as frequent as you want, and there's absolutely no mortality and morbidity which is associated with the whole organ transplant, so it's quite a safe procedure. Another great benefit of this is that the first metabolic benefits are observed within the first 2 days after transplantation, even before cells will migrate into form home into the liver, even in the site of the implantation. If you create pocket methods and tissues and all, those cells begin to secrete albumin within the first 48 hours. That was proven by the research which is done in Japan. There's multiple routes of implantation, either intraportal, subaponeurotic, intramuscular, and all. It depends on whatever is available in your facility. You can use it both for acute liver injury, for chronic liver disease, various metabolic syndromes. And it's something that is very obvious. You can follow up these patients easily, and you can sort of validate the outcomes very fast, by liver function test, reduction of ammonia, reduction of encephalopathy, and cardiovascular instability. The only thing that we have to do now is just gain more experience It's obviously that interest to the hepatocyte transplantation is increasing for the past few years, but not as much as we want. Okay, so it's still not many clinical trials, and all in very selected countries, it's like Japan and our group, you know, that are interested in doing this. Chronic kidney disease. So about 4 years ago, we have published this article, and it was a retrospective analysis of treatment of patients with the CKD. Mostly we have selected patients D8AB with the intermediate state of the CKD. That's how the renal precursor or the kidney precursor stem cells look like in the mitochondria in the blue state. There's also very interesting experimental data that we have, and it was more than 10 years ago, and they've evaluated the histological micrografts 6 weeks after the transplant of the renal precursor stem cells. And there's presence of actively proliferating cells, both exogenous and endogenous. And I'd like to remind you that it's extremely important for humans, because we exhaust our renal precursor stem cell pool by 36 weeks of gestation. So it means that 1 month before we're born, we lose ability biologically to regenerate our kidney tissue. And it explains why the CKD is a chronically progressive disease. You know, there's almost no reversal to that. However, if you use the fetal precursor cell therapy, targeted cell therapy, which means the implantation of the kidney precursor cells to the recipient, then you can downstage, you can regenerate tissue, and you can downstage the disease. Cardiomyopathy, and ischemic heart disease and cardiomyopathy. This is a very challenging task, you know, because you have to not only target regeneration of the cardiomyocytes, and these cells, they have to be mechanically and electronically coupled. So they have to be integrated in the entire system now, so that they are really functional. Apart from that, you need to promote new vascular genesis, create new blood vessels, re-establish blood supply to newly regenerated myocardium, and of course suppress the inflammation and the apoptosis of the cardiomyocytes and promote the remodeling via the peregrine effects. If we want to talk about cardiac regeneration, first of all, everyone has to read the work and at least be familiar a little bit with the work of Olaf Bergman and his group. And because for many years, until recent, heart was considered to be as a post-mitotic organ. And these guys, they have done the research, the C14 analysis, and they've on a huge amount of people, a huge population, and they found out that still there is a process, the so-called annual cell turnover of the cardiomyocytes. It's very low, unfortunately. So individuals who are 20 years and above, it's about 0.4, 0.6%. So only 0.5% of the cells regenerate per year. And if you look at the biological age of the cardiac myocytes, they're almost at large, as old as the patient is. What does it mean? It means that if you will stimulate the intrinsic cardiac repair, it's hopeless. You won't be able to achieve it. You can't achieve it in absolutely healthy individual. If you have an individual with a cardiomyopathy or ischemic heart disease, it's absolutely ludicrous idea to do that. And problem number 2 with the heart is the cell retention. You know, the interventional cardiologists, they inject the implant cells as close as possible to the affected area, which is infused through the coronary arteries and all, but the retention of the cells is very low. This study was done a few years ago in Netherlands, and they showed that a few minutes after the direct injection there's a washout of the cells. And also the longer the implantation compared to the actual acute event, the less is the percentage of the cells going to retain in the myocardium. So it's a How about neurodegenerative diseases? Probably cell therapy and the stem cell treatment is the golden standard. Not even in future it will be a golden standard. It is now already been recognized as a golden standard in treatment of various neurodegenerative disorders. Whether it's treatment of stroke or a treatment of dementia, Alzheimer's, or whatsoever. It's definitely the precursor neurons that are able to perform the actual replacement of the cells and take over the function in that area if we're talking about the stroke. If we're talking about Parkinson's, for example, that's a quote from this article. They're able to survive, cells are able to survive and migrate to lesion brain areas and survive up to 7 months. They also differentiate, perform a final differentiation into the dopaminergic neural fibers in close association with host neurons and express a glial cell line-derived neurotrophic cell factor. So it means that transplanted cells, they're only not capable of successfully incorporating the patient's tissue, but also they're able to create a cell-to-cell interaction with the recipients of the host cells. The initial outcomes in the early 2000s, the clinical benefit was about 30%. But as you improve the cell preparation and technology of how cells are produced, how they're cultured, we can improve the efficacy up. We have improved the efficacy up to 75%. So if you have, if you take patients with dementia and Parkinson's, and also about 3/4 of them, they will have the reduction of symptoms, irrelevant of what stage of the disease it is. And also we have learned that there's practically no very minimal immune reaction from the side of the recipient. It's 14 weeks after transplantation of fetal neural progenitor cells. There's only mild infiltration with immune cells and macrophages in the area of implantation. I'd like to share with you also this article. It's a very interesting case. It's quite a long time ago, you know, it was published almost 20 years ago, around 20 years ago. But it was about the very first, one of the first human clinical trials regarding the involving the xenotransplantation of neuronal cells into patients with Parkinsons disease. And there were 12 patients in this group. One of them has passed away, I think 7 or 8 months after the transplantation because of the cause of death was not related to stem cells. He died because of the acute pulmonary embolism. But because he was a subject for the clinical trial, he underwent the postmortem, and they've found out that 7 months post-transplantation, patient brain had surviving and functional xenogenic neural cells. And not only they survived, they found out, they were able to prove with the dopamine marker that these cells with the tyrosine hydroxylase, which is a dopamine marker, that these cells were dopaminergic cells. They were producing dopamine. And patient had, by the way, quite a dramatic recovery from Parkinsonian symptoms. And also they have identified that there are extensions of the exons and the dendrites of the transplanted neurogenic cells, and they created interactions with the neighboring recipient cells. So it's a unique case, you know, when we can get actual tissue proof, the tissue diagnosis, and the proof that transplanted stem cells survive not only for a few weeks, they survive quite for a long term, and they are able to perform the adequate function. This case, more than 10 years ago, it's a full-blown Alzheimer's together with the frailty syndrome, muscular dystrophy, cardiomyopathy, you know. This patient presented to us in the age of 82 years old. He underwent a full range of stem cell treatment. You can see the wife's feedback and attended his primary physician feedback, which when he was sending him for treatment, he was almost hopeless, I mean the physician. Okay, so he said that if anything happens to the patient and he dies, you know, please arrange for the body to be sent back to Australia where he's coming from. You know, but patient did not only survive, he actually responded tremendously well. And these pictures are taken by him and sent to us 5 years after he's done treatment. These photos are from 2013. The actual treatment was started in 2008, 2009. And then 4 or 5 years down the road, the patient not only recovered from the frailty syndrome, not only improved in terms of his sarcopenia, he tremendously improved in terms of his cognitive function. He's been able to travel the world, go to other countries independently, and he was even featured in a newspaper. So where are we headed in the future? We need to improve delivery methods. And by improving the delivery method, we need to improve the engraftment rate. So we come to the conclusion that the more different routes of implantation you use, the better is the efficacy. So when we deal with patients with neurodegenerative disorders, Apart from intramuscular implantation, creating the pocket, it's called the pocket method, with huge amounts of neural precursor stem cells, and that amount can be counted by hundreds of millions per vial. So in total, we can transplant up to a few billions of cells each transplantation. But we cannot transplant that huge amount of cells using the intrathecal implantation. So the volume of the cells that we can give is about 4 or 5 million of cells. It's only about 2 to 4 milliliters that we can inject directly as intrathecal implantation. But when you combine these two methods of administration, you get a much better outcomes than you just use one of the routes of administrations separately. We have tried autologous cells, we have tried non-specific MSCs for intrathecal implantation, not as great as neurogenic progenitor cells. So model change, especially when it's a high hypogonadism, or premature early menopause and andropause. And we have a couple of publications on this topic. We had a small pilot study trial done in Asia a few years ago, and we had a larger cohort, and it was published recently. So we have selected patients with premature menopause and andropause with all the clinical symptoms confirmed biochemically. And we have put patients through our treatment protocols. And the great news for this is that when you deal with, when you sort of activate the hypothalamic hypophyseal adrenal axis, it's not necessary to use stem cells even all the time. You can achieve the same target with a specific cell extract. So it has to be specific cell preparation that will activate the function of the hypothalamus, pituitary gland, adrenal cortex, and the gonads, both in males and females. So it's a gender-specific pattern. And when we put patients on our treatment protocol, we have seen that quite fast, within the first 4 months post-treatment, those who had decreased levels of testosterone was normalized and was kept quite stable throughout the year. It starts sliding down by the end of the year, but still it doesn't return to the initial point. Treating such patients, it's quite a task, so you have to alternate treatment modalities. Sometimes we need to give rest to the endocrine system, and use some mild forms of the HRT. And in the same time, it's very important when we do cell therapy, when we activate the hypothalamic hypophyseal axis, we need to load them with a sufficient amount of the precursor hormones, like the DHA, propranolol, and so on and so on. The same we have done in the female population, in a female cohort, and we had quite nicely increased estrogen level and decreased FSH, and the results, the outcomes are quite stable for up to 1 year. So what to do after 1 year? So probably you can bring the patient after 12 months, 16 or 18 months for the second round of cell therapy. So I'm almost done here, and I would like to summarize this. What to do? So the call for action. First of all, when we treat patients, we have to look at all the biological markers of aging more precisely and more in details, including the genetic and epigenetic test and the parameters of the oxidative stress and the mitochondrial function and all. So in our panel of standard investigations that we do in our practice, it's tens, sometimes hundreds of different parameters that we take into consideration. Second, it has to be a multimodal, multi-step therapeutic approach which we call it cycles. It's like you give a stressor, you give a treatment, and you give a relief. And biologically speaking, that's probably one of the best ways to regenerate tissue. You cannot give treatment continuously throughout the entire life of the patient. It just doesn't take anyone anywhere. It has to be incorporation of all the novice anti-aging strategies, starting with, I tell to my patient it takes 2 hands to clap. We're going to do 80% for you, or 90% for you, but you have to help us. We are not asking you to go run and jog or exhaust yourself in the gym, but high intensity training, 15-20 minutes, done once or twice a week, with a little bit of caloric restriction. The most effective way is intermittent fasting. And that will do a great job because it will activate specific genes of longevity. And we're going to add on treatment with the AMPK activators, and the sirtuin system upregulation, and the downregulation of the PI3K and the mTOR. When it's done together, and when you use the NAD as a catalyst for that, you are actually reversing the cellular aging. You are reversing the cellular senescence. And that gives you a wonderful opportunity to perform tissue regeneration. How to perform tissue regeneration? It is possible to be done only with the specific to the tissue precursor stem cells, or cell extracts, or specific tissue-specific peptides which will stimulate the repair, intrinsic repair of the tissue. In order to make that happen effectively, you need to prepare patients' biological terrain. You need to suppress their systemic inflammation as much as possible. And you have to flood them with a huge amount of growth factors that will promote survival, differentiation, and engraftment of the precursor stem cells. That can be done just with 1 day infusion of the non-specific MSCs, 1 or 2 days prior to the precursor stem cell transplantation. And what do you do after that? You need to continuously feed the cells that you have transplanted. And that is done with about 2 to 4 months of tissue-specific growth factors or the cell extracts therapy. And these all are naturally occurring substances which are procured from the same stem cells during their culture. Thank you very much for your attention. Any questions, please get my phone and discuss. Thank you. Yes, please.
Dmitry, always great to see your lectures. This is my third country for you, so always happy. But here's my question. I mean, even though I've been doing anti-aging for 25 years, I've always hesitated to get into stem cells because of the delivery methods. Because there's so many people given volumes of stem cells that are doing almost nothing. Now, I know that fetal precursor cells also, the majority do get stuck in the lungs. So my question is, and you're one of the few people I would actually trust for an honest opinion, is...
Really appreciate it.
Are the amounts of, I know how you feel about MSCs, but are the amounts getting through the 15% or so that are getting through the lungs to the potential target organs, is that enough to make the treatment worthwhile for the majority of people? Because this is what's held me up from doing it. I mean, I'll do them in the skin, I'll do them in the joints, I'll do them if I can get them into the organ.
Yes.
But if I can, it concerns me that I'm not doing the best thing for the patient.
Absolutely right. Great question. And that's why we're coming to the conclusion that when you use one route of implantation, it's going to be least effective. 50% going through the lungs, whatever is infused IV, believe me, this figure is too optimistic. Okay? It's much less than that. Much, much less than that. There was a meta-analysis for the multineuron disease and the ALS treatment with stem cells, and they compared intrathecal, intramuscular, and intravenous. And they found out that the IV implantation is the least effective. Now, here is the thing. It's not only by which route you implant cells, but each route of implantation will tell you what is the volume of cells that you can give. Whatever you give IV, well, you can go up to 30 million cells per day. And most of it is going to be in the lungs. Whatever will still circulate, whatever will reach the blood-brain barrier, for example, and whatever will pass through the blood-brain barrier, it will be a tiny, minuscule amount. You can compensate that with the intramuscular injection because when you do subaponeurotic or deep tissue implantation, the amount of cells that you can give is tens of hundreds of times higher. You can count by hundreds of millions or billions of cells. So you actually push the actual volume of the cells, hoping that with about the same percentage, the same ratio of delivery to the target tissue, you will just increase that amount of cells that will be delivered. Intrathecal is great, but very small amount that you can give. Certain compartments which are closed compartments, like joints, for example, there's no point giving it systemically, because it will never end up there. This is common sense, yeah. So there has to be the implantation there, what you want to treat. We do collaborate with the American Academy of Stem Cell Physicians. They are mostly from the East Coast, and also they try to find new ways of implantation, like the SPG block, and so on, and trying to do the intranasal exposure to the cavernous sinus. So hopefully that you will improve the delivery. Okay, so it is still the work of the future, and we are trying to sort of combine different methods of delivery and see which one is better. But so far it looks like there's no method which is better, but the combination of different routes of implantation, then what works best. I hope I answered your question.
You did.
Thank you. Yes, please.
Thank you for the lecture. It was very interesting. One question though. To the patient with premenopausal
Premature menopause.
Premature menopause or andropause, did you do the transplantation to the gonals or systemic?
No, it's a systemic. And now here's the thing. Those patients, most of them, they did not require the actual stem cell transplantation. It was the growth factors. It just was done by the peregrine effect. Well, first of all, because they're young, okay? Secondly, because we have ruled out major like iatrogenic factors and things like that. Yeah. So why they're developing premature menopause or andropause, it's not really clear. It's mostly the urban population, the people who are tremendously overstressed, you know. So that's the mechanism why they develop it. So there is, yeah, there is no problem with them per se, you know. There is no problem with them. All that you have to do is just reactivate them. Okay. So and as I said. It's not only the reactivation, you know, you have to load them, you know, because all these things like the low cholesterol diet, you know, and all these things, you know, it essentially deprives us of those essential nutrients which we need, you know, to create our hormones and so on and so on. You know. So when we put patients on the we load them with that, you know, and even with the lecithin, you know, things like that, and we give them a short relief. For 1 month, 2 months, 3 months, which is overlaid with a very mild HRT. And after that, you can do, or before that, and after that, you do the cell therapy, which will stimulate the endogenous production. You know, the entire axis. That's how we get results.
Will you check heavy metal toxicity or not? Will you check heavy metal toxicity in this patient or not? Heavy metal toxicity.
What toxicity?
Heavy metal.
Oh, whether we do the heavy metal, we do the heavy metal toxicity. We do check. It's not that whether anything, like any correlation or something, no, I haven't noticed it. I haven't noticed it. Thank you. But whether we have to implant that directly to the gonads, no such thing, just systemic administration. Now, this is a course of treatment. This is not a one-off implantation. Usually, they go twice per week. The protocol is about 5 to 8 weeks. After you stop, of course, you give still the support with the nutraceuticals and all, yeah. But you don't have to carry on this therapy for a long time, okay? And you don't have to repeat it for the next 6, 8 months or even a year. Thank you. Yes, please.
What is our status for the cardiomyopathy? How you are delivering stem cells arterially or directly to the myocardium?
Well, it depends on the facility who can do what in your facility. But thing is, even during the open heart surgery, if you implant, that's what they've done in Netherlands, you know, and with the help of the interventional cardiologists, the washout of the cells is very, very fast. You know, that's a problem. It works well for acute event, mostly, but if you want to treat the cardiomyopathy, not really. The retention of the cells is very, very low. That's the nature of the myocardium itself. So whatever you implant systemically, either IV, IM, the higher again the dose and higher the frequency, that probably will help us.
Do you mean if someone having acute MI, that's the best time to give them the stem cell? Somebody having a heart attack, give them the stem cell?
Yeah, that's only for the acute, yeah. But after that, in the long term, once the patient develops the cardiomyopathy, no, nothing will hold them. There's one study, DOMA, because most of these, the cardiomyopathy studies were done in Netherlands, but there's one study, DOMA, they showed that 2 weeks or 14 days, yeah, 14 days post-implantation, 0.4% of cells retained in myocardium. All right, sure, no problem. Any more questions, please? Wonderful. So, thank you very much. You're an absolutely lovely audience.